and I'm really happy to see you all joining us today for this edition of the CBITS webinar series. We're really delighted today to welcome Dr. Pablo Boczkowski to our webinar series as our presenter today. Dr. Boczkowski holds doctorates in clinical psychology from the University of Belgrano in Argentina, as well as in science and technology studies from Cornell University. He completed a 4-year interdisciplinary residency in mental health at the Alvear Hospital of Buenos Aires, Argentina, before moving to the US to retrain in science and technology studies. He was an assistant professor at MIT from 2001 to 2005, and since then, he's been at Northwestern with a primary appointment in communication studies. His research program examines digital culture from a comparative perspective, with a special focus on Latin America and Latinx USA. Boczkowski is the author of 7 books, including Digitizing the News, Innovation in Online Newspapers, which is the only book in history of the International Communication Association to receive both the Outstanding Book Award for Best Book Published in the past 2 years and the Fellows Book Award for making a substantial contribution to the scholarship of communication, as well as the broader rubric of social sciences, and has stood some test of time. He also has co-edited 5 volumes and written over 60 journal articles. His most recent book, co-authored with Northwestern grad student Maura Matasi, To Know is to Compare, Studying Social Media Across Nations, received the 2024 Global Communication and Social Change Award from the International Communication Association. Boczkowski's current research centers on the digitization of mental health work. And he's been a member of the School of Social Science of the Institute for Advanced Study at Princeton, is a fellow of the International Communication Association, and a recipient of the Distinguished Career Award from the Communication, Information Technologies, and Media Sociology section of the American Sociological Association. Finally, before he starts us off on his presentation, he did want to share a quick content warning. He'd like to share that during my upcoming seminar, I plan to share ethnographic material that includes reference to difficult mental health issues, such as death, suicide, self-harm, substance use, trauma, different forms of violence, and loss, which could be upsetting for some. I bring this to your attention in case you may wish to opt out of attending. Many thanks for your understanding and consideration. All right, with that, go for it. I'm really excited to hear from you.
All right. Thank you very much, Jessica and Andrea, for this wonderful invitation. It's a pleasure to be here with all you virtually. And I'm about to present work in progress. Your feedback would be most appreciated as I start the process of writing the book. So Maura is an early adopter of Skype for clinical work, something she started doing in the late 2000s. She's a seasoned psychotherapist, and give me a second, also a bit of a social media influencer. And when we met in March 2023, she told me that she had once presented about virtual therapy at a conference a decade before, and that, quote, if the audience had had tomatoes, they would have thrown them at me. It was sacrilege. And suddenly, as necessity has the face of a heretic, in 2020, they kept the tomatoes and made sauce. She added that just as there is face-to-face or the couch, I also think of the virtual as another variable to consider and decide. Now, the following dialogue took place with Evelina, another clinical psychologist, whom I interviewed her 2 years later in December 2025. Evelina said many patients who inquire about treatment do not even ask whether it is face-to-face or virtual. They are surprised when I ask whether they prefer one modality or the other. It is quite naturalized, I think. So I said, so in your perception, the virtual option is like the default and the alternative is face-to-face. Exactly. I said, but this is like an inversion, and she completes the sentence, of what it was previously. These 2 interview excerpts illustrate a significant change in the mental health professions in a remarkably short period of time. Face-to-face has gone from being considered the only legitimate modality of treatment for well over a century to first becoming one more option and then turning into a rarity for many. The depth, breadth, and speed of this turn of events should not be underestimated, since despite the many changes that have marked the evolution of clinical work, including the existence of teletherapy options, as Maura noted, and Berkeley historian Hannah Zibin's research has recently documented at length, Until very recently, the default modality of treatment was in person. So in this seminar, I want to probe the dynamics and the consequences of this transformation in modalities of treatment as a window into the digitization of mental health work and its larger societal implications. Now, historical discontinuities of this kind make more visible to the analyst social and technological configurations that were less visible before, as actors re-examine previously taken for granted processes and assumptions and develop new procedures and rationales for them. In addition, historical discontinuity of this kind can help better perceive connections that tie the workplace to larger societal dynamics. Now, this historical discontinuity is also mirrored by a certain imbalance in the literature, which has paid limited attention to the materiality of the therapeutic setting. A key takeaway from the emerging relevant literature that has tried to redress this imbalance is that, as Andreas Meyer has summed it up in his book Sides of the Unconscious, quote, in the development of the various methods of psychotherapeutic treatment, the positioning and manipulation of things and bodies mattered as much as the words uttered and their interpretation, end quote. But how exactly does the repositioning of things and bodies matter when treatment in person ceases to become the default option? To answer this question, I will take a cue from the idea proposed by Michel Foucault in The Order of Things that, quote, ethnology and psychoanalysis are sciences of the unconscious, not because they reach down to what is below consciousness in people, but because they are directed towards that which, outside of people, makes it possible to know that which is given to or elude their consciousness. Drawing upon this idea, my argument is that focusing on the historical discontinuity in modalities of treatment makes it possible to understand related discontinuities regarding inequality and culture that have been less salient in relevant scholarship. So to start addressing these matters, I want to now take you to Hospital Interzonal de Agudos Evita, named after Eva Perón. It is located in the Lanús municipality of the province of Buenos Aires, a relatively poor area, approximately 15 kilometers away from downtown Buenos Aires. I conducted fieldwork at El Lanús, the Lanús, as this hospital is popularly known, in September 2024. The picture on the left of the screen was the first thing I saw as I approached the hospital. It joins the two perhaps most iconic people in 20th century Argentine history, Eva Perón and Diego Maradona, since this is the hospital where the legendary footballer was born. The picture on your right shows what I saw when I entered the hospital. A bust of Evita presides the space, and to her right, there is a 1986 World Cup trophy and medal, a replica of that, arguably Maradona's highest accomplishment. El Lanús occupies a special place in the imaginary of mental health professionals in Argentina in particular and Latin America in general, due to its pioneering role in a number of policies and procedures starting in the 1950s. Chief among them, and of special importance for my account, was making psychotherapeutic services at the time dominated by psychoanalysis accessible to hospital patients, regardless of socioeconomic means. Evita, Maradona, and Freud, our pagan holy trinity. It doesn't get any more porteño, as the people from Buenos Aires are called, than that. So much so that around the corner from the Faculty of Psychology at the University of Buenos Aires, where I did my undergraduate studies, you can nowadays enjoy the true Nesca Freud, about which the creator of psychoanalysis claims to have tried it and found it cathartic. This advertisement also notes that any customer can purchase it via their mobile phone using the financial transaction app Mercado Pago. Porteño bricolage at its finest, my friends, joining the 19th and the 21st centuries seamlessly and ingeniously. Now, going back to El Lanús, Sergio Boczkowski, who wrote the definite account of its mental health unit, states, quote, the Lanús is an important link in the history of psychoanalysis in Argentina, especially with regard to its presence in the public domain, and with social sectors that do not usually demand it in a spontaneous way, end quote. Furthermore, historian Mariano Plotkin, whose Freud in the Pampas is perhaps the most comprehensive analysis of the appropriation of psychodynamic ideas in Argentina, concurs. Mauricio Goldenberg, the chief of the service, is credited with modernizing the Argentine mental health system and with introducing psychoanalysis in public hospitals. He then adds a comparative angle by noting that, as in the US, the psychiatric services established in general hospitals played a very large role in the diffusion of psychoanalysis, primarily because they brought psychotherapy to low-income patients who otherwise had no access to it, end quote. Driven by progressive ideologies that were common among professional elites from the 1950s to the 1970s, Goldenberg and his collaborators aimed to provide continuity of care between public and private contexts to help mitigate the effects of socioeconomic inequalities. This emphasis on continuity fascinates scholars to this day, as we can see most recently in Xochitl Marcili Vargas's Genres of Listening and Samuel Icolu's Into the Loop. However, explicitly or by omission, this continuity emphasis either disregards socioeconomic inequalities or underscores commonalities across strata. Does this continuity of care also apply to the modality of treatment? My informants who work in public hospitals tell me that treatment there is still in person, which differs markedly from their private practices. But this is not the only discontinuity they experience professionally between both settings. Candela, who works at El Lanús and is a clinical psychologist, tells me that, quote, the life stories are terrible. All this is a manifestation of how the psyche survives so much poverty of so many generations, economic, cultural, and relational poverty. It is all very broken. You are no longer guaranteed health in general and mental health in situations in which someone does not eat or have a family, or somebody who was born without a family in the street, who was sold, who was given away. People arrive like that. I was given away to such and such family, who in turn sold me, and so on. So later in the interview, she adds, there is so much inequality. The life of so many people is so unfair. That really hurts me. The difference that I find in myself is that when I listen in private practice, there is an internal relief. Well, this person is not suffering from something terrible. I mean, they're suffering from their own psyche or from their relationships or from, I don't know, but they're not suffering from the basics of living. And that is a relief, because in the hospital, their suffering hurts me all the time. To Joaquina, a colleague of hers and a psychiatrist at El Lanús, work also hurts. Almost all of us do psychoanalysis as patients, because this is Argentina. We work on our angst and we see how to get out of this situation as professionals, suffering as little as possible. She adds, the patient remains in limbo. Do you know what limbo is? It's the professional body. That's what they told us in a supervision. The professional ends up grabbing the patient and carrying the patient on their shoulder, end quote. She illustrates the situation with the following story, quote, last Friday, we, referring to her and a social worker who was nearby as I was interviewing her, ran for 4 blocks, and then our superiors challenged us for doing that, and we all started crying. I'm telling you something tragic anyway. A 14-year-old patient, so that she wouldn't be at risk in the street, we brought her in a police car so that she didn't have to go home where the abusive father is. But we don't have to do that because it was too much. And we have been the previous Friday in La Plata, which is a municipality 60 kilometers away from Lanús, for 10 hours for her to be hospitalized in a facility that has child and adolescent psychiatry. But they did not take her. And after 10 hours of waiting, they gave her a letter telling her that she had to come back here. Tried to do a referral to hospitals in even poorer municipalities like Rafael Calzada or Monte Grande. Now, it turns out that in a previous trip, I had interviewed Selva, a psychologist in Monte Grande who works in a public hospital nearby. She shared that there, quote, the internet is a headache. They brought us the little cameras, the headphones. I was laughing my ass off. The treatments are in person because when they came with all this story, and I say story because it was a fantasy about telemedicine, it was impossible. First, because there were professionals who flatly refused to do virtual work with the patient. Second, because with only one computer for a mental health unit with 15 professionals who work with approximately 1,500 patients in total per month, How could we do it? It was impossible, impossible. And third, because nobody was going to use their personal devices, end quote. She summed up her analysis with a powerful statement. Virtuality is a matter of class. Now, from continuity of access to psychoanalysis in the 1960s to discontinuity of modalities of treatment in the 2020s, and from the public health attempts to lessen socioeconomic inequalities to the widening of these inequalities and their subjective impact on both patients and professionals, this brief account of the realities of work at El Lanús, then and now, begins to illuminate what is at stake in the digitization of mental health practice. But before I go deeper into the findings, let me briefly situate the inquiry. I have chosen to conduct this research in the metropolitan area of Buenos Aires, which is home to 14 million people and accounts for almost half of Argentina's GDP. I have selected this location for three reasons. First, because of its large number of mental health workers, Argentina has the highest proportion of psychologists per capita in the planet. For instance, it is 8 times higher than the US, and Buenos Aires actually more than triples the national average. This allows me to access relatively new phenomena at a location where it is likely to be expressed with particular intensity. Second, because of its high rates of adoption of technologies that are critical for this project, namely messaging services, social media, and mobile devices. According to the most recent government statistics, 97% of the population own a mobile phone and 92% use WhatsApp. This suggests that there is no shortage of technology that could hinder the deployment of low-cost remote treatment options. Third, because of the deep inequality and growing impoverishment of the Argentine society. Two variables which are central to my study. The deterioration in material conditions is so significant that most of the country nowadays lives in households below the level of poverty, households in which an adult makes less than $8.50 a day. And that includes 18% of the households below what is called the indigence level, in which an adult makes less than $4 a day. This is an interview-based study focused exclusively on professionals. Scholars such as Summerson Carr, Tanya Lerman, Emily Martin, and the above-mentioned Xochitl Marcili Vargas and Samuel Ecolo, as well as Andy Lakoff in Buenos Aires, among many others, have written insightful ethnographies drawing upon observations of therapeutic work. However, I have decided not to conduct observations of sessions for reasons having to do with inequality in obtaining informed consent. Patients from lower socioeconomic strata tend to have more differential attitudes towards healthcare professionals than their counterparts from higher strata. Therefore, asking permissions to observe sessions, the former might have had greater difficulty denying such permission than the latter, thus potentially leading to complicated ethical scenarios and sample bias. The interviews are all in person, last an hour on average, take place at the time and location chosen by the interviewee, and any quotes are anonymized using pseudonyms. I have conducted 141 formal interviews between December 2022 and January 2025. Previously, I had also talked to more than 20 professionals informally during 3 trips I did before the start of fieldwork to help develop the research design. Except for one interview, which included 2 participants, the rest were with 1 participant. 3 people were actually interviewed twice. So you can see the breakdown by gender, profession, and age on the screen. Finally, during the most recent trips, I have conducted more than a dozen member checks, some with key informants and others with former interviewees. These conversations included sharing an earlier version of the seminar that I'm presenting today, about which one key informant concluded that, quote, "I have become the analyst's analyst. We tell you things that we don't tell ourselves." So, as I mentioned before, treatment in person remains the default modality in the public sector. There are infrastructural, organizational, and experiential dimensions that relate to these findings, and there are also exceptions to this pattern. To start addressing these infrastructural issues, I would like to take you now for a couple of minutes to the neighborhood of agronomy in English, in the city of Buenos Aires. Across the street that you see on the left, every day of my life from 1940 to 1990 to 1994, I wasn't alive in 1940. The picture on the left side of the screen is the entrance to the Alvear Hospital, where I did my residency training in clinical psychology during those 4 years. You can see the entrance to the residency offices on the right side. Immediately after finishing that training, as Jessica said, I left to pursue a doctorate in science and technology studies at Cornell in upstate New York. I took these two pictures when I visited the hospital for the first time in 29 years while doing fieldwork for this project. When I stepped into the hospital, there were many spaces in which time had stood still, including the entrance of the residency. Now, the two offices in this figure belong to two different units. They look almost identical to the rooms in which I conducted therapy back in the early 1990s. Paper is still the dominant medium of communication and record keeping. There are other communication and information technologies present, like the no longer functional payphone that you see on the left side of the screen, which is a requiem of an era gone by. When I did my training, it was not only functional, but it was also the epicenter of social life in the hospital for two reasons. First, since no professional staff, patient, and family member had mobile devices, this phone was the lifeline to the outside world. And second, adjacent to it, there was a small outdoor cafeteria where different members of the community gathered for cheap coffee and pastries. Nowadays, the cafeteria moved indoors, has Wi-Fi and air conditioning, but when I went there, it was almost empty with only a handful of patrons and everybody looking at their respective phones. Now, this leads us to the presence of digital technologies. The picture on the left shows a CPU and a monitor on the shelf above, and an older functional desktop computer on the desk below. What you cannot see is that this is a storage room in which these technologies lay adjacent to mundane artifacts such as crutches and baby strollers. The picture on the right shows one of the newer offices in the outpatient unit, which is a significant upgrade from the other consultation spaces that I showed you. These images depict a significant level of infrastructural poverty for offering remote treatment at scale. Although every public hospital is different, this poverty is common across all of them. To mitigate it, professionals often donate equipment, subsidize connectivity costs, and/or ask pharmaceutical laboratories to contribute towards this end. However, the limited infrastructure available is almost never used for communication with patients. On the contrary, professionals take advantage of it for tasks such as data entry for clinical records, consultation liaison, supervision, and training. Infrastructural poverty coexists with organizational constraints that further contribute to make treatment in person the default modality. To begin, professionals tell me that there are very limited resources, especially relative to the level of demand, which is perceived to be exceedingly high and continuously rising in prevalence. In addition, department chairs and unit leaders often discourage, curtail, or even downright prohibit professionals from engaging in remote treatment, even if they may wish to do so. This is remarkable given that for these patients, going to the hospital represents a non-negligible portion of their income, and most of them have access to smartphones, as the statistics mentioned above show. The combination of high levels of poverty among the patient population and of serious technological and organizational limitations contribute to rising levels of frustrations among professionals. So Norberto is a psychiatrist who split his time between public hospital work in the morning and private practice in the afternoon. And he says, quote, "Our department, which treats at least 1,500 patients a month, does not have a telephone. And there is no official email of the department either. Every time the patient is absent or wants to communicate, they have to go to the hospital. Outside of work hours, we have no contact with the patients. It ends up being a political decision of the service directors to organize it that way." And he adds that until a little more than a year ago, we, the professionals, paid a company that provided us with the internet. Larissa is a psychiatrist who joined another public hospital in 2019. She shares that I am very much in doubt about continuing my work here because it is a lot of sacrifice. The hospital nowadays feels very heavy. It is in a situation of infinite demand. So you get there and you know that you have to solve 500 problems. The situation is burning us, end quote. In line with what we heard from Candela and Joaquina at El Lanús, she adds, this generates a lot of anguish in me, like a level of trying to respond to something that exceeds me. And her voice breaks and she starts tearing up. And some situations like this happen at least a dozen times in the fieldwork of professionals getting into tears after discussing their work situations. It gives me the feeling that we always fall short. Once it's saturated, sick professionals all the time. Many of them quit, and many who do not quit but go on leave. She also notes that during the pandemic, virtual consultations were endorsed, but afterwards, as soon as we went back to face, they were completely suspended. The head of the service said, that's enough, there is no more virtual assistance, it's over. Marcelo, a child and adolescent psychiatrist, tells me that the public sector work is taxing for him. So I ask him how he handles it, and he answers, what a question. Sometimes I want to run out of the trenches and every person for themselves. I have tried to organize teamwork, territorial work, but I had run of illusio, as Bourdieu would say, or I have little left. So I have to take care of myself as a person, my body, my subjectivity. Sometimes I get home very tired. I live with my partner who sometimes tells me that I become irritable and that everything bothers me. Martin is a psychologist in his 50s, works in a public hospital emergency room in addition to his private practice. He recently had to take a leave because of burnout. He tells me that since returning, something is happening to me that didn't happen before. Before coming to work, I get anxious because I already know that I'm going to find a disaster in the ER. On the day prior to the shift, starting in the afternoon, the anguish begins. So I ask him how he deals with that, and he says, well, I stay in my house, among 17 pine trees, park, swimming pool, birds, I breathe, I disconnect, and eventually a benzodiazepine. Now, there are exceptions to the portrayal of work presented, work in the public hospital presented so far. Renata is a fourth-year resident, physician, a psychiatrist, who shares the story of a patient who was in a situation of gender violence. In the pandemic, it worsened because she stayed locked in her house all day with her son and the violent man. It ended up being difficult because she had an overdose and the violent husband ended up calling me in a very threatening way. It was a difficult situation to handle, but it was essential at the same time that the patient had our contact. Otherwise, the treatment would have been lost and she needed it. She was a patient who called us 4 or 3 times a week. She would say, hey, I need to talk. I'm overwhelmed or I'm afraid. If she had not had our contact, it would have been unsustainable. There were moments that were chaotic, but we also got a lot of shit from our bosses. But hey, I have no regrets. We were able to accompany her. She was able to leave the house and managed to move to another apartment. Antonia is a psychiatrist who works in a public hospital as well as in private practice. When I first interviewed her at the beginning of the study in December 22, she mentioned that she did remote work with a quarter of her hospital patients, adding that, quote, because one of them had suicidal risk, I made her come to the hospital and now she's coming in person. But I had been treating her virtually by phone since the pandemic. During an earlier round of data analysis, I became intrigued by the fact that she did remote work in the hospital, so I requested a follow-up interview almost a year later to learn more about her experience. At that time, in October 23, she told me that, quote, the hospital no longer registers the sessions as valid if they are by telephone, because for control reasons, the person has to come and check in at the service. At this moment, I'm seriously considering resigning from the hospital because the atmosphere is very dense of pressure on us. It is becoming such a mess that I cannot stand it. Jasmine is a psychologist and the director of mental health services for a municipality of over 500,000 people in the greater Buenos Aires. Her case gives us a glimpse of exceptions at the organizational level. She oversees the work of 45 professionals who provide 7,000 sessions per month. It was 5,000 sessions 5 years ago, she tells me, but demand has been on the rise in recent years at an increased rate of 500 to 600 new sessions per year. To deal with this rise in demand and cut down wait times to less than a week, she implemented a system whereby patients have to contact the municipality over the phone first, and an initial conversation leads to an email with instructions for the appointment. This municipality offers remote treatment, and Jasmine says that this modality, quote, is in general by Meet. What happens is that we set up this email so that the Meet hyperlink can be generated automatically. Some of the sessions are overtime that are done from the home offices of professionals, and professionals can also use remote treatment to replace some of their in-person work. Now, the stories shared by Renata, Antonia, and Jasmine show possible alternatives to the dominant pattern that results from the exercise of individual and organizational agency, an issue to which I will return in the concluding section of the seminar. Overall, this account of modalities of treatment in public hospitals, however, shows the dominance of in-person work within the context of harrowing levels of poverty and inequalities among the population, exceedingly limited infrastructural resources, rising organizational constraints, and taxing experiential consequences for professionals. Because the financial compensation in the public sector is very low, professionals who work in it almost always have a private practice. The stories that I hear about private practice are starkly different from the ones they share about the public setting. So the metaphor that has arisen in my mind as the fieldwork has progressed is of professionals who work in two radically different countries and cross an imaginary border every workday. My interviewees have usually found the metaphor evocative when I shared it with them. So having spent most of this talk so far on one side of the border, I now invite you to get your passports ready and join me crossing to the other side. When we cross the border, we see significant variation regarding modalities of treatment. Sometimes this variation is by treatment, when the same professional treats some patients in person and others remote. Other times is within a specific treatment, which is when either the professional or the patient or both request a modification to the modality depending on issues ranging from clinical needs to scheduling convenience. Yet on other occasions, it is by professionals, mostly in the case of professionals who work only remotely, although I also have in my sample a handful of professionals who almost only treat patients in person. However, all of them are open to remote options. In general, clinicians evaluate remote modalities to be good enough in most cases, inferior in others, unsuitable in a minority of cases, and almost never superior. They also nearly universally find them less enjoyable than in-person work. Now, 4 factors shape variance regarding the choice of modality of treatment in private practice. They are, in descending order of prevalence, the preferences of the patient, the nature of professional dynamics, the relevance of specific clinical considerations, and the overall work experience. I will take 10 minutes to address each factor separately. Preferences of the patient. So, professional referrals and new patient requests almost always start via WhatsApp. They commonly include information about what the new potential patient prefers regarding the modality of treatment. Interviewees tell me that if they do not match this preference, the prospective patient usually seeks assistance elsewhere. 2 main factors guide patients' inclination towards remote treatment: geographic distance and everyday logistics. First, mental health services had historically been limited by geography, but nowadays, if professionals are willing to forego jurisdictional regulations, these services are instead limited by language. Driven partly by the economic crisis, having patients overseas who pay in foreign currency and often under the table has become highly desirable for professionals. Moreover, for patients in the US, fees charged by professionals in Argentina are a fraction of what they pay out of pocket after insurance coverage. Within Argentina, the remote modality can be appealing for patients in either isolated rural areas or small towns where there is little privacy. And finally, traffic in Buenos Aires has become so congested that the remote treatment becomes a convenient option for patients who live close to the professional's office. Second, professionals report that patients' work schedules have gotten more demanding and their everyday lives busier. For patients in clerical and knowledge work, taking a 50-minute break between tasks to have a remote session lowers the barriers of access. The same applies to middle-aged parents juggling work and child and elder care. Patients gain the possibility of having a session, but lose the reflection afforded by the dead time going to and from sessions. However, that dead time seems to be vanishing from everyday life among people in the middle and upper classes, who go hurriedly from one thing to the next, attempting to optimize their time in the pursuit of the most possibly productive existence. Gaston is a psychologist who sees an average of 45 patients per week in his private practice. He comments that in Canada, a Spanish-speaking therapist met a Mexican patient and didn't understand him at all. So the patient's father, who's a doctor, knew this patient of mine from Puerto Rico, so I go to Canada virtually. There are days in which I am with someone from Barcelona, and then I go down to Malaga, and abroad I must have 15 patients. Esteban is a psychoanalyst who has, quote, 8 or 10 patients from abroad. After the pandemic, I started seeing patients who live in Barcelona, Madrid, Mexico, New York, Washington, Uruguay. Before the pandemic, I had one patient in Colonia and another one in Montevideo. These are 2 cities from Uruguay. They traveled by ferry, came here, had the session, and went back. At that time, the technology existed, but it never occurred to us to see each other virtually. With the pandemic, we said, hey, that's it. Mirta is another psychoanalyst with a couple of decades of experience who, since the onset of the pandemic, has only seen patients remotely in her private practice. She says this modality works, quote, magnificently, even with patients who were on the couch and turn off the camera. There are 10 patients who I've never seen in person. There hasn't been demand from the patients to return to face because they take advantage of the break they have in their home office. And moving around the city is a madhouse. However, Marta, who's also a psychoanalyst, offers a cautionary reflection about remote treatment. I think if one can work at home, have contact with the office, and at the same time stir the pot in the kitchen, one's positioning is different. You lose this thing about entering a space almost religiously and leaving and going to another space. Everything now is much more mixed. The second factor shaping the adoption of virtual modalities has to do with professional dynamics. Professionals, including psychiatrists in particular, tend to be more comfortable than psychologists with remote work. However, most psychiatrists who treat a patient remotely prefer to do so after they do the initial interview in person. Furthermore, within clinical psychologists, CBT professionals are better predisposed than psychoanalysts to work remotely. However, this does not necessarily affect the prevalence of remote work, only the level of comfort with it and the extent to which they question its limitations. Furthermore, professionals also experience an increase in the pressures on their work time and on their personal and relational lives. On the one hand, demand for services has risen. On the other hand, the same social forces at play for patients also apply to them as people. This has made the remote modality also convenient for them, which they can undertake from their homes and even their vacation spots. Finally, clinicians have also suffered directly or indirectly from the effects of Argentina's economic downturn. This means that the cost of an office space has become higher to justify within tighter budgets, which also nudges professionals towards remote work. So Julio, a cognitive behavioral therapist, comments that the remote treatment opens the market and the costs become cheaper. You don't have to rent an office, you pay for the internet, and that is the cost. Psychologists usually do not talk about money because we think we are priests, but priests are priests and psychologists are psychologists, and we psychologists, like any other person, want money. But Fernando, highly regarded psychiatrist, knows that, having a patient in Miami does not appeal to me at all. Besides, there is a logic of responsibility to which you cannot respond when you work in this way. Finally, Beatrice brings up an interesting pattern. Most interviewees who are also patients prefer the remote modality for reasons that are not unlike those put forward by their patient. I do therapy, she says, but virtually. I don't have time to go in person. Why do I do it? For convenience. Yes, I could have another relationship with my psychologist if it was face to face, but I don't know if I'm willing to spend 3 hours between coming and going to do that. There are certain types of problems that professionals often say that they do not treat remotely, such as any condition involving risk to the patient and to others, and certain types of addictions, psychosis, and depressions. Conversely, they note that other conditions lend themselves quite nicely for remote treatment, including ADHD and some sleeping problems. In addition, almost all interviewees also highlighted some groups with which they prefer to work in person, such as young children and patients in specific work arrangements. Finally, they also repeatedly mentioned that decisions on the modality of treatment are not fixed. If a remote patient worsens or has suicidal ideation, for instance, they are asked to continue in person. Pedro, a cognitive behavioral therapist whose practice used to be exclusively in person, noted that he switched to remote work entirely since COVID and has had good results. The treatment of insomnia, he says, and ADD is quite structured, so that facilitates the work of the online modality. It's like after the pandemic, treatments on the screen became naturalized. And he adds, I don't notice any difference in performance with in-person work. However, he concludes that, quote, I find it hard to believe that it is possible to work in the same way with personality disorders or even with patients with affective disorders that are decompensated. In the interest of time, I'm going to skip a couple of examples here and go to the fourth dimension before I wrap up. Now, the most mentioned experiential matter has to do with issues of embodiment. Professionals complain about the loss of embodied information, from size to gesture to smell to sound, when they work on the screen, as well as the complications that arise from centering the gaze on one part of the body, the face, and the inability to look at each other in the eyes. Several interviews also underscore the difficulties with what they consider the bidimensional sonic experience of remote treatment and share compensatory measures such as the use of various sound systems and headphones. Silence also comes up in interviews. Professionals note that it is difficult to maintain it for longer periods of time during the remote modality. Furthermore, they can sometimes have a glimpse of where the patients live. However, they often feel that they do not know how to take advantage of this new information source. This might be because it is more taxing on the screen. Attention is more taxing on the screen than in person. With very few exceptions, interviewees note how more tired and distracted they are when they work remotely. They connect tiredness to feeling they must focus more intensely on lesser sources of information about the patient, and distraction to the presence of digital interruptions to their concentration, such as notifications and text messages. Finally, professionals talk repeatedly about how remote modalities on the one hand help them deal with busier and more demanding work, but on the other hand add to their workload and blur the boundary with their professional lives. Evaristo notes that in a psychotherapeutic interviews, there are some silences that must be sustained, have weight, and are important. In my experience, this function of silence is one thing in person, and virtually something of that is lost. Something that technology brought with it is this idea of the immediacy of everything. And that idea blurs or denaturalizes silence in the moment. Perhaps the presence of the body there in front of you gives another form to silence. If you are in a place with a screen in front of you, in the moment of silence, there is no other body present apart from yours in that silence. There is the computer with the image, but there is not that other body making silence as well. Diego spends many hours in the office and that is increasing, he says. I would prefer to work less anyway. I work around 50 hours a week. I think everyone is oversaturated. He adds that I started to have many patients who live in other countries, and this is also why I have more work now. Sometimes I work from very early in the morning because I treat patients in Europe. And I stay very late because I see patients in California. This has extended my schedule. And sometimes I wouldn't feel like working on a Saturday at 6 or 7 p.m. But if I do it on Zoom, it doesn't bother me that much. Finally, he shares that I feel that I don't need to disconnect and that this must be very worrying. Sometimes when I disconnect, go on vacation, or I decide to disconnect, it's like turning off a refrigerator that makes noise. I also play tennis 3 times a week, go to the swimming pool, watch TV. I have a good life. But it is true that when I disconnect, I realize I needed it. But sometimes I'm so connected that I lose even the notion that there is such a possibility to disconnect. And at one point, when I went on vacation last year, I thought about keeping the sessions with my patients online. Crazy. Now, Diego's reflections, which resonate with those shared by Beatriz, Marta, Mirta, and many others, coalesce to generate the image of an everyday culture that is aching or like insulation foam, a substance which expands in contact with air and occupies every crevice that can be filled. Therefore, professionals inhabit a contemporary everyday culture that expands across national borders, across times of the day and time zones, across the office and the home, across the work and vacation spheres, across productive and non-productive time, public and private, self and others. This expansion entails another form of discontinuity with El Lanús and the iconic 1960s, when the demarcation between spaces, places, times, and selves was clearer and the boundaries less porous. Therefore, if my analysis of the modalities of treatment in the public hospital foregrounds a fractured society, this analysis or account of the private office work brings to light an expansive everyday culture. Now, let me conclude by reflecting on some key methodological, empirical methodological, conceptual, and societal implications that arise from this brief foray into mental health work at the very end of the world. And I only take 5 more minutes of your time, I promise. To begin, my account illuminates empirical discontinuities in social structure and everyday culture. On the one hand, an increase in poverty and inequality and a decrease in upwards mobility. On the other hand, an expansiveness regarding places, spaces, times, and selves that are busy, optimized, and ever more stimulated. These discontinuities are orthogonal, as they stem from different sociocultural transformations, and we can imagine situations in which we have one but not the other. But they also variously intersect in the lived experience of my interviewees, for instance, when they take patients overseas for greater economic gain and work longer hours to make up for lower domestic fees. Moreover, and to build on the theme of continuities and discontinuities, I have enacted a perspective on technology and work that is starkly different from the usual approach these days. That is, instead of treating technology as a tool, for instance, what this or that AI application or platform affordance does for professionals or how it impacts society, I have viewed digitization as a lens whose exploration enables the analyst to understand social, economic, and cultural matters that dominant account elide. The technology as tool approach is not intrinsically bad, but it often predictably misses aspects of the social that are critical to achieve both better descriptive fit and greater heuristic power. This is particularly salient regarding agency. In the technology as tool approach, materiality almost always has too much agency, and so do large and often evil corporations. Yet, the presence of exceptions to the norm and the ways in which professionals and patients use to their advantage social media, messaging service, and conferencing platforms shows the extent to which lesser actors have agency and can creatively appropriate technologies that often have negative valence in the relevant scholarship. Furthermore, in recent years, most of the scholarship of technology and society has either disregarded class or treated it as a derivative factor from other primary variables. Although this might be appropriate under certain circumstances, class is a primus inter pares explanatory factor in my account. While this is not applicable to every context, I suspect it might not be unique outside of the wealthy countries. One issue is the increase of inequality where there is limited poverty and reasonable levels of upwards mobility. Another is when it is coupled with significant levels of poverty and limited upwards mobility, which sadly is a situation not only of Argentina, but also most of the world. Now, in addition, and even at the risk of stating the obvious in particular for this crowd, it is noticeable the extent to which taken together non-clinical factors such as context of services, patient preferences, and professionals' personal circumstances account for most of the variance regarding modality of treatment. Given the dominance of the official rhetoric around evidence-based psychotherapy and psychiatry, my account yields a starkly different picture. This invites us to re-examine the design of both clinical guidelines and public policies in pragmatic ways. Otherwise, we might fail to harness in a realistic fashion the potential of digitizing mental health work. Finally, there is a fascinating and ironic paradox at the nexus of the discontinuities in social structure and everyday life present in my account. On the one hand, those who might need remote modalities the most typically cannot have them. On the other hand, those who might be better positioned to resort to in-person treatment often choose not to take advantage of it, and this includes the professional as patient. This paradox troubles the logics of ideology, clinical optimality, and individual self-interest in explaining social action. If progressive ideas were the dominant driver of practice in the public sector, we should have seen higher level of effort to realize the possibilities of remote work. If the maximization of therapeutic value and the care of the self were the main forces behind decisions in private practice, we should have also seen higher level of effort directed towards the in-person modality, which also applies to the potentially beneficial effects that the professional's own treatments might have regarding their work. Therefore, ideological preference, clinical rationality, and individual self-interest do not appear to have much explanatory power. Paraphrasing the closing line of Peter Gallison's Image and Logic, some dominant explanations, my friend, also come to an end. Thank you very much.
Thank you so much. That was super fascinating, and I think a very different perspective on these kinds of issues than a lot of us are used to hearing about and reading about and studying. So really refreshing to hear this perspective and set of methods being used to the fullest, particularly the reliance on in-depth interviews. I think that is something that psychologists could certainly learn from a little bit more. So we have a couple of minutes for questions. So if folks do have questions for our speaker, please do go ahead and leave them in the chat. We'll probably have time for one or two maximum. But to kick us off, since there aren't questions in the chat just yet, I think because people were so riveted by your presentation, they were all just watching. I'd love to hear your thoughts on how a lot of the interview results that you shared speak to the increased risk of burnout and the differential risk of burnout among therapists based on their own sort of context, their own privilege, the resources available in their environment. How do you see that affecting the quickly growing telehealth workforce? And what do you think the implications might be for folks accessing telehealth-based care?
That's a great question, Jessica, and thank you very much for your kind comments. So there are two aspects of that. So telehealth definitely lowers barriers of access. So it is likely to grow. Telehealth, that's on the patient side. On the professional side, telehealth also has significant economic advantages and convenience advantages. Now, having said that, what almost unanimously everybody that I have interviewed says is that the telehealth option tends to be associated with higher levels, at least of distress, if not burnout. And that distress is cognitive, right? I mean, people say that they can go, for 8 sessions in a row in person, but no more than 3 or 4, right, on the screen. Number one. Number two, the effort that they have to pay, they think, and the processing dynamics go on overdrive, so they are more tired. And number three, there are actual physical issues. People complain anything from lower back pain to shoulder pain to weight gain, etc. So there are two forces here, conflicting with each other. On the one hand, telehealth is socially beneficial. So there are welfare effects for society as a whole, right? On the other hand, it is more economical, but it also, as it is associated with, negative health outcomes for the professionals. My hope is that this kind of study and studies of this kind in general can lead us to first call attention to this issue, right? There is a hidden cost to telehealth that we need to pay attention to, number one. Number two, develop policies and procedures for that. In the same way that there are policies and procedures for residents, for surgical residents, no more than X hours, this or that, perhaps we need those policies so that we can reach the sweet spot of how to utilize these kinds of opportunities. Does that answer your question?
It does. Thank you so much. We have a couple other questions. We probably only have time for one, unfortunately, so I'm just going to read the one that came in first. Question from an anonymous attendee. Do you think that while psychoanalysts are entertained with silences, CBT therapists are focused in using telehealth to reach more of the population? Would you be willing to explore the repercussion of psychoanalytical school of thought being hegemonic in public healthcare?
Those are two different questions.
Yeah.
I'm gonna go quickly because by the way, my email is available on the Northwestern website.
Yes.
If people want to email me questions or reach out, feel free to do so, especially for Jose Luis and Zoe who ask questions and I will not have time to answer them. So psychodynamic schools of thought from the Freudian to the Kleinian to the Lacanian used to be very, very dominant in Argentina. Nowadays, they are much less dominant, in particular among professionals who are 35 and younger. Most of the residents and the younger professionals are, the psychologists are going more into CBT work or DBT in some cases, depending on the patient population. And for the psychiatrists, they used to be very psychodynamically oriented. They are much more neurobiological oriented now. So it is not as dominant as it was before, number one. I lost the first part of the question answer. I'm still here. So the CBT professionals, it's not that they are more willing to use telehealth. Everybody's willing to the same degree. It is just that silences have different meanings, as we all know, for a CBT practitioner than for a psychoanalyst. And the silence in person is a very powerful intervention. And it's much more difficult to sustain remotely, also because of technological issues. Connection drops, you don't know what's happening, etc. So I don't know if that answers. And I see now 4 different questions. Email them to me because I know we are at time,
Yes,
Jessica.
unfortunately, we are at time, but yes,
Happy to
absolutely
answer them.
send follow-ups via email. Thank you so much again for that really interesting presentation.
A pleasure.
Really grateful you could join us today, and I hope everyone has a good rest of your Tuesday.
Excellent. Bye now.
Here.